Hello everyone, and this is a broadcast that we are making for you. And I wish my voice is very clear. Hello everyone, and this is a broadcast so that we will begin our lesson today. And it will be a very important lesson, so please listen carefully, and we will be studying this important subject. The subject today, it is very clear and everyone can see it on the screen. Here we have the circulation and hemorrhage control, of course. And I hope it is very interesting subject for many of you that haven't heard of such thing before. Starting from the beginning, we have our lecture here, and it discusses the different aspects of ATLS. First of all, what is ATLS? It's an advanced trauma life support, as you can see it here. And I wish you can focus with me in this subject. This subject is very important, I repeat, and it needs a lot of focus from everyone involved in this lesson. Let's go ahead and start giving you a general idea about the ATLS. ATLS is an advanced trauma life support. And this advanced trauma life support is written by our doctor that he has given this information to you, and we will be presenting it to the casual listener. Preparation and transport. Of course, you can write your comments here if you want. And this will not be a very long chapter. It will only be like about 10 minutes of information. So anyway, preparation and transport we have here. Then after preparation and transport, we have the pre-hospital phase. That includes airway maintenance, control of external bleeding and shock, immobilization of the patient, communication with receiving hospital, and immediate transport to the closest appropriate facility. Also, the history taken, which includes the event that has taken place. Primary survey, ABCDE, airway and cervical spine control, breathing and ventilation, circulation and hemorrhage control, disability, like neurological status, and exposure environmental control. These all should be maintained and taken a good notice about. Airway maintenance with cervical spine is also an important thing to notice here. The causes of upper airway obstruction may be bleeding from oral or facial structure, bleeding from oral or facial structures, aspiration of foreign materials, teeth, dentures, etc., facial fractures, is another airway obstruction that could happen to the patient, airway structure trauma, regurgitation of stomach or stomach contents. Some people will regurgitate the food or regurgitate acid reflux. Commonly, the upper airway is obstructed by the position of the tongue, especially the unconscious patient. Also, we have the hematoma. Control of airway is another method. The chin lift is to maintain the patient's breathing capability and capacity. Jaw thrust, suction, oropharyngeal and nasopharyngeal airway. Also the laryngeal, we have the laryngeal mask airway also is important. The laryngeal tube airway, and that will be discussed later. Surgical and definitive airway. In this picture, we can see the chin lift. We can see the jaw thrust plus suctioning. Then, the definitive treatment here is also important to the patient. Definitive airway defined as an inflated cuffled tube in the trachea, and its type is orotracheal tube, nasopharyngeal tube, and other than definitive treatment that is indicated on the orotracheal and nasotracheal tubes. Recommended and indicated in the patient that is unconscious, apnea, and with the inability to maintain potential airway, the need for protect of the lower airway from blood and vomit, and the need for mechanical ventilation. This is a surgical airway with needle cricothyroidectomy. Until now, there is no comments to this YouTube channel, but that's okay, because anything you want to comment, I will be commenting on and give my opinion if you have a question. Next, we have the surgical cricothyroidectomy. This is also important to maintain the patient's life and vitality. Cervical spine control with the patient sustaining injuries above the cervical or with a decreased level may be a cervical spine injury. Avoid hyperextension or hyperfixation of the patient neck, and definitive cervical spine control is required. How to immobilize the patient is another subject that we will be discussing here. Right away, of course, I will be discussing to you, and you will be understanding, hopefully, immobilization, semi-rigid cervical collar, head blocks, and the tape over the forehead and chin, as you can see in this picture. Breathing and ventilation. First, we do the inspection, palpation, and auscultation. Inspection includes the to see if the chest has any bruising and a subclavian emphysema, distant jugular vein. Sometimes it is distended. Also palpation. Chest should be palpated frequently, and the ribs should be examined and maintained. Inspect for any wounds on auscultation and lack of abnormal breathing sounds. This is on auscultation by hearing the voice of the heart, etc. When it comes to shock, the most common cause of shock is traumatized patient in hypovolemia caused by hemorrhage. And this shock causes an organ damage, such as brain, kidneys, inadequate blood supply to vital organs. Decreased intravascular volume also. Decreased intravascular volume, second to blood loss, lead to decreased pulse pressure. Rapid pulse, diminished capillary refilling, cool, clammy skin, and decreased urinary outcome. Management of hypovolemic shock. How to manage the hypovolemia? 2 large bore intravenous lines placed 14 or 16 gauge. The antecubital fossa are the preferred sites. Antecubital fossa. You can look it up on Google if you don't know where it is. Neither I do know, but it is generally somewhere in the hand of the patient. A blood specimen should be simultaneously obtained for cross-matching. Resuscitation should consist of an initial bolus. For pediatric is 200 ml to protect the patient from hypothermia and from urinary and gastric catheter should be indicated. Control of bleeding, direct pressure to the wound, packing, ligation, etc. Disability should be inspected for disable AVPU method, alert, response to pain and unresponsiveness. Neurological assessment, GCS scale, and pulp reaction to light and limb movement. This is all important for you to understand this subject. I don't have to be angry on anything, but this is the Glasgow Coma scale. For many people to understand. First 4, then 5, then 6 points. First eyes, then verbal, then motor response. Starting with the eye, then going to the verbal, then to the motor. When the eye opens spontaneously, that's 4. Eye opens to speech, that's 3. Eye opens to response to pain, that's 2. And when there is no eye movement at all. Verbal oriented, that's 5. Confused, that's 4. Inappropriate words, that's 3. Incomprehensive, 2. And then none is 1. 4, 5, then 6. 6. Motor response, obeys commands. 6. Localized pain. And then withdrawals from pain, fixation to response to pain, extension to pain, and no motor response. With normal values, 15. 13 to 14 is mild. Less than 13 is moderate, and severe is 3 to 8. Let's go to the E, exposure control, use of patient warmth, increase room temperature, secondary survey is important, includes ample, and also we have this ample history, allergy, skull fracture, and you can see these pictures. There is a skull fracture and the CSF leakage. Carotid arteries may be affected also. Pupillary light reflex is normal. Size and shape and definitive care for comprehensive trauma and injury, etc. Stabilization of knee. That was our lecture today, and I hope you understand it very well. Please focus to it and read it many times.